So if your nose starts running, like every time you bend over to tie your shoes, a doctor isn't just going to hand you some allergy medicine. They're actually going to check if your brain is leaking.
Which, I mean, it sounds completely like science fiction, right? But it's a very real, very dangerous anatomical possibility.
Wow.
Yeah, clear fluid from the nose coupled with a change in posture is actually a major red flag for a cerebrospinal fluid leak.
And that wild fact perfectly sets the stage for what we're doing today. Welcome to the deep dive. We are looking at this really fascinating stack of source material today.
They really are. It's something most people never get to see.
Right. It's a set of handwritten clinical notes used by medical students and doctors in an ear, nose, and throat clinic, an ENT clinic. And what makes these notes uniquely compelling is that they're bilingual. They're written in this mix of English and Urdu.
Yeah, and the mission here isn't to give medical advice, obviously. We're trying to decode the secret language of these notes, to show you how a doctor transforms this really vague complaint from a patient into a hyper-precise medical investigation.
Exactly, because the next time you go to the doctor for like a simple sniffle or an earache, you're going to understand exactly why they're suddenly asking about your carpet or your teeth or if you sweat at night.
Because to the patient, this feels like a casual chat. But beneath the surface, the doctor is running this incredibly complex, multidimensional algorithm. They're trying to catch subtle physiological failures before they become catastrophic.
So let's start with the foundation of that algorithm. Before the notes even get to specific illnesses, they introduce this universal framework for interrogating any symptom at all.
Right, the DePuy-Sacat mnemonic.
DePuy-Sacat, yeah. It stands for duration, onset, like is it sudden or gradual progression, site, intermittent or persistent, characteristics, aggravating factors, and treatment, which means, previous medicines or surgeries.
It acts as an anchor. The second a patient walks in, the clinician immediately starts filtering their narrative through those 8 variables.
But I have to push back on this a little bit. Doesn't rigidly adhering to a mnemonic like DePuy-Sacat, doesn't it make a doctor sound like an automated phone menu?
That's a fair point.
It's like a journalist's 5 W's on steroids. If a patient is sitting there in agonizing pain and the doctor is just mentally checking off DOPS, it seems like it would just completely kill the human empathy of a checkup.
Well, yeah, and that is a tension every medical student wrestles with.
Yeah.
But you have to consider the environment they're in. A clinic is inherently chaotic, right? The doctor might be seeing their 30th patient of the day. The patient might be anxious or exhausted or just unable to articulate the exact nature of their discomfort. So the DePuy-Sacat isn't there to replace empathy. It's there to prevent cognitive overload.
I see. So it's basically a structural safety net.
Exactly. Yeah. Empathy is vital, but empathy without accuracy doesn't actually cure the underlying disease. When you only have 10 minutes to diagnose a problem, you need a framework that forces you to check your blind spots.
Right. And notice how the acronym adapts based on the chief complaint. Like for an ear discharge, the notes modify it to DePuy-Sacat-S, adding a check for skin changes.
Yeah, and they actually write out the Urdu prompt for the student there.
Which means asking if there are spots, redness, or sweat behind the ear.
Right, because redness behind the ear completely changes the risk profile.
Yeah.
It indicates the infection might have spread from the ear canal into the mastoid bone.
Oh, wow.
Yeah, which is a medical emergency called mastoiditis. Or if a patient has an earache, the notes use DePuy-Sacat-R, adding a check for radiation of pain.
Meaning, does the pain travel somewhere else? Which makes total sense anatomically, right?
Yeah.
Tracing where the pain radiates essentially maps out which specific nerve is inflamed. So let's look at how they apply this framework to the first major section of the notes, which is the ear itself. The level of specificity demanded here is just immense.
It really is. Take hearing loss, for example. The doctor doesn't just ask, if the volume of the world has been turned down.
Right, they ask if the loss is in high frequencies or low frequencies. And there is this fascinating Urdu translation note here. Awawaz sunai deti hai, lekin samajh nahi aati, which translates to, I hear the voice, but I don't understand the words.
That's a crucial distinction.
But why does the diagnostic algorithm care about the difference between hearing a tone and comprehending a syllable? Also, there's a note about intolerance to loud sound.
Well, because hearing is a 2-part process. It's mechanical and neurological. If a patient can't hear a sound at all, there's usually a mechanical blockage. Like the eardrum might be ruptured, or there could be fluid in the middle ear stopping the sound waves from vibrating.
But if they hear the sound and the words just sound like garbled nonsense, the mechanical part is working fine.
Exactly. The eardrum is vibrating, but the translation is failing, which points the clinician away from the ear itself and toward the auditory nerve, or the processing centers in the brain.
Oh, that makes sense.
Yeah. The cochlea is converting the mechanical vibration into an electrical signal, but the brain isn't parsing the data packets correctly. The doctor is isolating exactly where on the assembly line the breakdown is happening.
It's like having a perfectly good microphone, but the computer software recording the audio is glitching out.
That's a perfect analogy.
And this focus on hyperspecific characteristics also shows up in how they evaluate tinnitus, ringing in the ears.
Oh yeah. Tinnitus is notoriously tricky because it's entirely subjective. The clinician can't independently verify or measure the sound.
Right, the patient is the only witness. So the C in DePuy-Sacat characteristics expands into this massive checklist. They ask about the pitch. Is it high, like a pressure cooker whistle, or low, like a train rumbling?
And the one that really stands out is asking if the ringing is pulsatil.
Meaning, does the sound beat in time with the patient's own heart?
Exactly, because a pulsatil sound indicates a vascular issue, not an auditory one. The patient is quite literally hearing their own blood flow.
That's wild.
It could point to a narrowed artery near the ear, high blood pressure, or some abnormal connection between arteries and veins. It immediately shifts the focus from the ear to the cardiovascular system.
Okay, but I have a question about this part. The notes also instruct the doctor to ask if the tinnitus is aggravated by chewing or speaking. On the surface, that seems bizarre.
How so?
Well, chewing food is a jaw function. Ringing is an ear function. Why would chewing my food change the ringing in my ear? That sounds like a jaw problem, not an ear problem.
But anatomically, they share the exact same real estate. The temporomandibular joint, the TMJ, the hinge connecting your jaw to your skull, is separated from the inner ear structures by mere millimeters.
Oh, I see.
And they share a common wiring system. The trigeminal nerve innervates both the muscles used for chewing and certain structures within the middle ear, so signals can get crossed.
So severe tension or inflammation in the jaw joint can physically compress nearby structures.
Yes, or it sends distress signals that misfire down the nerve branches feeding into the ear. When a patient says their tinnitus spikes when they bite down, the clinician knows to check the jaw mechanics before assuming the inner ear is failing.
A symptom in one location driven by a mechanical failure in another. That's fascinating. And this concept of shared anatomical pathways actually provides a great transition into the next major section of the notes, the nasal cavity and the sinuses.
Right, because a problem in the nose rarely stays confined to the nose. The respiratory and auditory systems are deeply intertwined.
The symptom checklists in this section cascade, well, it's like a complex drop-down menu in a software program.
Yeah, that's exactly how it functions.
If a patient reports a simple stuffy nose, the clinician deploys a secondary mnemonic checking the M3 and S factors. M3 is mouth breathing, mouth dry, and mouth taste. The S factors are snoring, apnea, and sleeping episodes.
They're mapping the downstream physiological consequences of the nasal obstruction. When the airway is blocked, the body forcibly shifts to mouth breathing, which bypasses the nose's natural filtration.
Which explains the dry mouth and altered taste, right?
Right, the oral microbiome changes when it dries out. And it also fundamentally alters your sleep architecture.
How so?
Well, the airway is more prone to collapsing when you breathe through your mouth during sleep. That leads to hypoxia or low oxygen, which triggers the micro-awakenings of sleep apnea.
So the clinician is establishing whether a localized issue is degrading the patient's entire metabolic recovery cycle, but the menus go even deeper.
Oh, they do?
If they suspect the nasal issue is part of a larger syndrome, they use the FATA mnemonic, facial pain, anosmia, which is a loss of smell trauma, and allergy. And if the patient answers yes to having an allergy, the doctor deploys yet another mnemonic, LISA 2R.
This is where the detective work gets highly biochemical.
LISA 2, that's lacrimation, excessive tearing, itching, sneezing, skin allergies, aspirin intolerance, asthma, and recurrent sore throats. Asking about carpets or passive smoking makes sense for allergies. But why is the doctor suddenly asking if taking an aspirin causes a reaction?
The clinician is hunting for a very specific biochemical profile called Samter's triad. It consists of aspirin sensitivity, asthma, and the development of nasal polyps.
Let's unpack the mechanism there because it's not just a random correlation, right?
Not at all. It involves how your body processes inflammation. In most people, the enzyme pathways that manage inflammation are balanced. But in patients with Samter's triad, taking aspirin blocks a specific enzyme path.
The cyclooxygenase pathway.
Exactly. And that forces the body to shun all its resources down a different inflammatory pathway, causing this massive overproduction of chemicals called leukotrienes.
And those leukotrienes trigger severe localized inflammation. So in the lungs, that's an asthma attack. In the nasal cavity, it causes the tissue to swell and form polyps, which physically block the airway.
Right. So by asking about aspirin, the doctor isn't just checking for medication allergy. They are probing your underlying biochemical pathways to see if the nasal obstruction is a structural issue, a simple allergen response, or a complex systemic inflammatory disease.
Which brings us back to that incredible detail we discussed at the beginning of the deep dive. Under the aggravating factors for nasal discharge, the notes list bending or straining.
Yes, the cerebrospinal fluid leak.
Right. Clear fluid dripping from the nose when leaning forward is a major indicator of a CSF leak. But why exactly does that happen?
To understand it, you have to visualize the anatomy of the skull base. The roof of the nasal cavity is essentially the floor of the brain cavity. They're separated by this very thin, porous plate of bone called the cribriform plate.
It sounds like a pretty fragile border.
It is. If a patient experiences head trauma or even undergoes certain sinus surgeries, that thin bone can develop microfractures. And because the brain is suspended in cerebrospinal fluid.
The fluid just seeps through the fracture and leaks directly out of the nose.
Exactly. To the patient, it just looks like persistent watery mucus. But bending forward increases the hydrostatic pressure inside the skull, which physically pushes more of that fluid through the crack.
Wow. And if a clinician dismisses that symptom as just a stubborn allergy, the consequences are severe, right?
Extremely severe. A leak means there's an open pathway between the outside world and the brain. The patient is at extreme risk for bacterial meningitis. A single question about bending over acts as a literal life-saving filter.
It really emphasizes how localized symptoms often have these profound systemic roots, and that philosophy actually dominates the final section of these clinical notes.
Zooming all the way out.
Yeah, an ENT specialist deals with the head and neck, but the diagnostic matrix forces them to evaluate the entire body. The notes introduce two final comprehensive checklists, the EO system and the TNM system.
EEO stands for eyes, ear, and oral cavity. Even if a patient presents solely with an ear complaint, the clinician is required to run through this 8-point visual checklist.
They're checking visual acuity, diplopia, double vision color blindness, excessive tearing, and proptosis, which is eye bulging. They also check for neck rigidity with fever. Then they move to the mouth, checking for difficulty opening the jaw, dental pain, loose teeth, or a sudden change in voice quality.
It's a masterclass in neuroanatomy, honestly. The cranial nerves that control the eyes, the face, the jaw, and the vocal cords, they all originate in the brainstem and travel through these incredibly tight, complex pathways at the base of the skull.
So if a patient complains of an earache, the physical exam reveals they also have double vision and a hoarse voice.
The clinician knows this is no longer just a localized ear infection. It's physically impossible for a standard ear infection to cause those secondary symptoms.
So what does cause it?
Well, a mass, a tumor, or a severe spreading infection at the base of the skull could easily compress the cranial nerve controlling eye movement, the nerve servicing the ear, and the nerve traveling down to the vocal cords all at the same time.
The combination of symptoms pinpoints the exact geographic location of the internal pressure,
Exactly.
which introduces a much darker reality of the diagnostic process, leading us to the TNM and TB sections of the notes. TNM stands for tumor node metastasis, which is the universal staging system for oncology, and TB stands for tuberculosis.
This section highlights the intense cognitive and emotional translation the clinician has to perform. They're looking for signs of metastatic cancer or severe infectious disease.
And this is where the bilingual nature of the notes becomes so poignant to me. The clinician is holding this terrifying, high-stakes medical algorithm in their mind, but they have to translate it into approachable, colloquial Urdu for the patient.
Right.
The notes prompt them to ask, Rat ko pasina aata hai? Do you have fever at night with sweats? Wazan kam? Have you experienced weight loss? Kunto nahi aya? Is there blood in your cough? Under the metastasis checklist, they are checking for bone pain, backaches, chest pain.
The clinician is actively searching for evidence that a primary disease in the head or neck has seeded itself in distant organs.
The intellectual agility required there is just staggering. They're simultaneously inhabiting the hyper-technical space of oncology while remaining completely present in the highly vulnerable human space of patient communication. They are translating cellular-level metastasis into gentle questions about backaches.
And they must do it without alarming the patient prematurely. If a patient comes in with a stuffy nose and an earache, and the doctor suddenly starts asking about bone pain and coughing up blood,
Patient's anxiety will skyrocket.
exactly. The clinician has to weave these high-stakes questions naturally into the conversation using the Doptesac and EEO frameworks as a guide. It's a remarkable synthesis of science and empathy.
So let's trace the path we've taken through these clinical notes today. We started with the foundational structure of Doptecat, seeing how it prevents cognitive tunneling and anchors the clinician during chaotic clinic hours.
Then we examine the anatomical overlap of the head and neck, learning how tension in the jaw joint can manifest as a ringing ear, and how clear nasal discharge when bending forward can signal a microfracture in the skull base.
We delved into the biochemical pathways of Samter's triad, understanding why a doctor asks about aspirin intolerance to explain nasal polyps. And finally, we saw how the EEO and TNM checklists force the clinician to map local symptoms onto systemic diseases.
Translating complex neuroanatomy into accessible, everyday language. The overarching theme really is connectivity. The human body is a deeply integrated ecosystem. No single system operates in isolation.
Which leaves you, the listener, with a final fascinating concept to consider. We spent this entire time unpacking how deeply physical this diagnostic matrix is.
It is incredibly tactile.
It relies on the clinician pressing the bone behind the ear to check for mastoiditis. It requires observing the subtle bulge of an eye or identifying the specific smell of discharge. It's a three-dimensional process. So what happens to this invisible scaffolding in the age of telemedicine?
That's a great question.
As healthcare increasingly moves to flat video screens and digital questionnaires, how much of this intricate spatial and sensory algorithm collapses? If a doctor can't physically palpate your jaw or look deep into the nasal cavity to see the origin point of a fluid leak, how do they differentiate between a common cold and a systemic failure?
It fundamentally changes the nature of the translation.
It certainly does. The next time you log on for a virtual medical appointment, ask yourself, how many critical lines on the doctor's hidden anatomical map are being erased by the digital divide? We'll leave you to think about that. Thanks for joining us on this exploration of the medical mind.